Hey everyone, it's Hunter Hicks. Today we're going to look at pneumonia and some other causes of lower respiratory injuries and some upper respiratory injuries in adults and pediatrics. So what we're looking at here is normally how the pulmonary arteries come in, and then the blood goes back to our pulmonary veins. We have our alveoli, we have some lymphatics. So oxygen is going to diffuse through, and then CO2 is going to go out our alveoli. Now we call these Starling forces. We have good hydrostatic pressure over here on the left, where we are pushing fluid out into the interstitium, and then good oncotic pressure over here where we're pulling fluids in. Now what really helps keep this, a lot of our proteins here inside, like albumin, that help keeps good oncotic pressure here, good pushing pressure over here. Now, what happens with pneumonia in a lot of our causes here? So what happens usually is we have some degree of an infection, which is virus, bacterial, it could be a parasite, could be fungal. Well, what happens, we get a lot of inflammation going on here. So our capillaries get leaky. When they get leaky, we like to allow our proteins to come out into this space. Well, we know proteins like to pull, proteins pull our fluid, which is our oncotic pressure. So we bring fluid out here, and eventually we'll get fluid in the alveoli. Now, this is more an example of what we would call an indirect lung injury, right? Where there's some kind of infection somewhere else, and our white blood cells happen to come over here, and they attack our alveoli, thus making him more permeable and allowing fluid to accumulate in the alveoli. Now, this can happen really as a direct or indirect lung injury, and this is really what we call pulmonary edema. So pulmonary edema we can see, obviously, with pneumonia. It doesn't always occur, but we can, as we know our smaller bronchioles that are up here and our alveoli have all this exudate, which is like all the crap, right? The neutrophils that come and they die, and the bacteria debris, and even some blood from injury to the alveoli like you just saw here. There's just a bunch of stuff in the way of this gas exchange in the lower airway between our alveoli and our capillary membrane, which we call our AC membrane. So this is really ideally what's happening here with pneumonia. Now, this is more looking at pulmonary edema, which would be non-cardiogenic pulmonary edema, but obviously pneumonia can cause a degree of this exudate and fluid in the alveoli and all in this area. So pneumonia in general, our patients that are most at risk are going to be kiddos less than 2 years old, and then older people above 65. Now, again, like I said, usually some degree of something gets in the lower airway, causes this increased inflammation, and then causes these alveoli and bronchioles just to get full of all that crud. And it just likes to sit down there, causes shortness of breath, causes all the issues. Now, some of the causes, bacterial, more common in adults. So we know that Streptococcus pneumonia, which we just call pneumococcal pneumonia, is one of the most common things we see in adults. Outside of that, we can see Staph aureus, and then Mycoplasma, which we call atypical, more likely to see that in kids of school age. Viral can happen in both, but more common in kiddos. So we can see things like the common flu, influenza A or B. We can see rhinovirus. We can see coronavirus, as we know, going through the pandemic. RSV in kids, though, is the most common thing to call pneumonia in kiddos. Again, kids are more likely to get a viral pneumonia. Parainfluenza, and then adenovirus. Those last three are most common in kids, where RSV is one of the most common causes of pneumonia in kiddos, and obviously bronchiolitis, which we'll cover later. Symptoms are going to vary if it's viral or bacterial, but in general, your patient's very sick. Sometimes they had an upper respiratory infection before. Maybe they currently have one. Maybe they just had the flu. Obviously, viral in general disease can cause us to be more likely to get a pneumonia, as it decreases all of our nice protective mechanisms in the lungs, or if they have a viral pneumonia, it's breaking down all these protective mechanisms so they can have a viral and they can have a bacterial at the same time. But in general, sometimes their cough, they can have a productive, it's more bacterial, maybe non-productive if it's viral. They can have a fever, more bacterial, maybe a low-grade fever or no fever with viral, and stuff like that. So in general, they just look sick. They might tell you they've had this upper respiratory infection, they just can't fight it, they feel short of breath, or maybe they just had the flu and they thought they were getting better and then they got sicker, blah, blah, blah. As far as diagnosis, we'll look at some of their labs and look for signs of infection. So white blood cell count, usually higher in bacterial, not so much with viral. We can look at our CRP, which is a marker of inflammation, which is hard if they're already sick. And then procalcitonin, which we know is going to look more for a bacterial cause. Assessment, like I said, you're going to take everything in: cough, fever, shortness of breath, and knowing that maybe they were just sick or they are sick currently, anything like that. Chest x-ray is usually pretty good and pretty helpful here. It's going to look for consolidation. So consolidation is all the exudate, which is all that junk, whether it's the dead bacteria, the white blood cells, the neutrophils dying off, some of the blood, everything, all that junk is going to come up as white. As we know, we're going to see it as more like a fluid. It's a more dense material in the airways. Therefore, sometimes it can just be more condensed to one area, which could be like a lobar pneumonia. So it's just in one lobe of one of the lungs, or it's diffused throughout. Just depends. Treatment, if it's bacterial, we know we want to get culture. Sometimes we can do a sputum sample, but that's very difficult because there's a lot of other bacteria in the mouth already, so we can kind of contaminate it. We can do bacterial cultures as well, right? If the pneumonia is bad enough, some of the bacteria gets in the blood, goes around the blood, therefore we can pull it and see what it is. We want to get antibiotics on as soon as possible. Pulmonary hygiene and chest physical therapy is things we want to do for these patients. So pulmonary hygiene is things like deep breathing, right? As we deep breathe, we're moving more air, we're opening up those alveoli, we're preventing atelectasis, things that we need to do. We want them to be coughing, right? Sometimes people with depressed cough are more likely to get pneumonia, like our older people or some of our neurologic patients, because they can't expel that bacteria, therefore the bacteria sits in there and grows and causes this inflammation. Chest physical therapy is things to help break up that mucus and all that debris in there, hopefully to get it kind of loose and help them cough it out later. Hydration is big because a lot of these all the mucus and all that crap that's released in here, all the exudate is kind of thick, so we want to try and break it up with some fluid. And in general, they're probably sick with a fever, so they could use the fluid. Bronchitis, which we covered in chronic bronchitis with COPD, one of the umbrella terms of COPD, chronic bronchitis and emphysema. Bronchitis is just that. It's an inflammation or irritation of the large airways, the bronchi. Now, usually if this isn't a COPD thing, usually it's a viral cause. So influenza, coronavirus, common cold, stuff like that. Causes inflammation of those bronchi. They do all the things as they love to do, like increase airway edema. We get those goblet cells releasing more and more mucus, and in general we just get these lungs full of crud. Diagnosis is a little bit tricky because it looks like pneumonia and it can present with pneumonia, and they're kind of the same causes. Maybe they have an upper respiratory infection like the flu that causes bronchitis but not pneumonia. But it can also cause pneumonia as well. So you really got to be careful here. Chest x-ray is pretty helpful because if you look at a chest x-ray for pneumonia, if it's already moved forward, you're going to see the exudate as diffuse or consolidation in different areas of the lungs. Bronchitis is only large airways, meaning the bronchi. So you're really not going to see that consolidation. Whereas we know pneumonia, lower airway, bronchioles and alveoli filled with crud, we're more likely to see that on chest x-ray. Treatment's really symptom management, depending if you think it's a bacterial cause or not, because viral, we're not really going to do much there. So symptom management, maybe anti-cough medications and fever meds. Bronchiolitis. Now, bronchiolitis can definitely happen in both adults and kids, but we mostly see it in kiddos, and it's a lot worse in kiddos because their bronchi are already a little bit tinier. So anything to mess up that nice diameter and airway is going to cause some problems. Causes, RSV, the most common cause of bronchiolitis. Now, there are other causes, but this is by far the most common. Symptoms, rhinorrhea, they're going to be snotty usually, right? We know they're just having all the snot come out of their nose, which is why one of the treatments we know we do in the hospital or even at home is suctions. We want to try and hoping to open up this oral nasopharynx airway and not let them swallow any of that snot and stuff. Fever is very common to see here, cough, and wheezing. The wheezing we know is when you have a nice open bronchi, the air just goes in and out, no turbulence. However, when air goes into something that's closed or trying to close with edema and all this fluid and stuff, it goes ding, 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 and that turbulent flow causes the wheezing. So it's pretty common to get wheezing with bronchiolitis. Now, in general, when we look at treatment, we're going to first try and figure out what it is, what we're fighting. So a lot of times the viral panel, do a little swab. Again, RSV, one of the most common. And then we can also, sometimes if you want to do a chest x-ray, not always needed, but chest x-ray will look hyperinflated, meaning bronchiolitis is a common cause of one of our obstructive causes. We know obstructive causes things like COPD and asthma. Now we have another one, meaning these kiddos have issues getting air out of the body because those bronchioles are bronchoconstricted with edema and all the mucus in there. Therefore, we bring air in, but the air can't get out. So they're full of all this air, so they get hyperinflated. We know that when these poor kiddos get hyperinflated, it pushes on our nice muscles that they use to help them breathe. Well, when all this is hyperinflated, it's kind of pushing on those muscles, and it actually makes it even harder for them to breathe. So we kind of get this mixed bag here. They can't breathe well because all the crap's in the way, and then they get more hyperinflated, which causes it even harder to breathe. So we can definitely see that here as well. These kids usually are obstructive patients, but they can obviously get very, very hypoxemic. As we just decrease the amount of air moving, they're going to get a degree of hypoxia. Common things we can do for bronchiolitis: fever management, fever, treat that, help them out. Give these kids fluids. We know in general they have a fever, they have a ton of insensible losses at home, they've probably been sick for a few days, they're tachypnic, so they're breathing off, and they're probably not feeding too well or drinking a lot because they're mad, they're sick, they feel like crap, they don't want to. So they need help, they need fluids, and it helps break down all those things. Okay? Steroids can help decrease that hyperinflammatory state, and then support with oxygenation. Now, some things we can do at home is anything to kind of help break that stuff up. Sometimes nebulizers can or can't help, but maybe some of that humidity can help out here as well. Last but not least, croup. So croup sometimes is caused by different names here, but really what we're saying here is croup can be laryngitis with tracheitis, meaning inflammation of the larynx up here, which is kind of where we find our voice box, like our supraglottic, epiglottic, and glottic opening down through the vocal cords, right? We have our tracheitis, our inflammation of our trachea, and then bronchitis, or inflammation of our large airways. Now, commonly, we don't really think of it that way, but it really can be all inflammation of all these guys at the same time. Now, this happens anywhere from 6 months to 5 years, most common to seeing kiddos that are 2 years of age. Common causes, parainfluenza, one of the most common causes of this, but look at who is back, RSV and influenza. So in general, the flu can cause a lot of these, and RSV can cause a lot of these, but parainfluenza, one of our biggest causes here. Now, some of the symptoms here in general is going to be they can come just looking sick again, right? Rhinorrhea, they have that stuffy, they have that nose that's just pouring out snot. Everyone knows the textbook thing we can see is this harsh seal-like cough. The reason for that is because they have that laryngitis usually, and all their vocal cords are just inflamed and mad and upset. We have that subglottic airway, subglottic edema, which is below the vocal cord, so that little opening is very, very tiny. So in general, they can have a harsh seal-like cough, and they can also have a hoarse voice, which again, we just call laryngitis. They can have stridor, which is from upper edema, upper airway edema, and then sometimes a low-grade fever. Now, I want you to be really careful with these kiddos because a lot of our croup can just be at home, easy peasy, don't need to do anything. Not easy peasy, but doesn't need to go to the hospital. Now, in general, one of the biggest things we do for treatment, try and keep these kids as calm as possible. The reason for that is because there's so much resistance, right, from all the edema. They're going to try and pull harder. They're going to try and pull air into their lungs harder. They're like trying their best to pull air in down there. Well, what that does is that creates more negative pressure in the lungs. So when you're creating more negative pressure, your upper airway wants to always do this. Close off, close off, close off. We know our airways always try and do that, right? Obstructive sleep apnea, we do it up here. Now here in croup, we're trying to close off that airway. If they do that, that's going to make them freak out even harder because now they're like, oh my God, now I really can't breathe. So they're going to breathe even harder and harder and harder. So if we keep them calm, move that air nice and easy, we have less likely to create that negative pressure and close off that airway. So you try and keep them as calm as possible. Treatment really depends on severity where they are. Steroids can help maybe bring down inflammation. Obviously, we're in the hospital. We're talking about racemic epi, but we're not talking about that here. But steroids can help break down that inflammation. And then cool air, because we have swelling, you probably don't want to give a lot more hot air because that might not help at all. So cool air and even some mist, right? Some nice humidification to maybe help kind of break and calm everything down in there. But cool air in general is what we want to do. That's all I got for you guys today. If you have any questions, leave a comment. Give me a like if you want, and I'll see you next time.